Okay, so again, because our airways all the way down to our lungs are open spaces, we have to create some kind of mucus, something sticky to trap the particles. But we don't just want to trap them, we also want to get them out. So these are some of the things that we're going to be talking about throughout this lecture on the respiratory system. And then, of course, the gastrointestinal system is one big, long, giant tube that runs through the body. But it has some openings, right? Obviously, if you're going to eat, it's going to go in this area. Everywhere there's an opening, your body's going to create some kind of mucus. So when I talk about the respiratory system and you're breathing air in, think about the pathway of the air and think of how open that is to the rest of the outside world. It's completely open. The only thing that's stopping our airways from filling up with all of these particles is mucus that can trap them and can help get them out. Now, some people say, well, what about hair, like the hairs that's inside of your nose? All right, yeah, but it's not the hair itself that traps the particles. The hairs just sort of stick out from the side, like this. So the hairs are going to help in the fact that they're going to create an extra block for things that are coming in. But the hair themselves aren't going to trap the particles, but there's going to be a lining of mucus, a coating of mucus that runs down all these hairs. So the hairs are just projecting the mucus into the nostril, into the center of the nostril. So as you breathe air in, particles coming in are going to get filtered to a certain extent by those attractive nose hairs. So FYI. So the respiratory system, you'll see, is not complicated in its anatomy. The physiology is a little more complicated. Like I said, I'm just sort of going to scrape the surface of it. But the anatomy itself is not too difficult. But it's something that we have to be acutely aware of because obviously we're all breathing. Now, what is the purpose of breathing? Why do we breathe? And you cannot say to live. Obviously, we want to live. But what's the purpose? What do we get from breathing?
Oxygen.
Oxygen. And what do we use oxygen for?
Energy.
Go ahead.
Energy.
Go ahead, I'm sorry.
Yes, energy. We have to create, every cell in our body has to create energy. And the three main ingredients in creating energy are glucose, oxygen, and water. So we have to have oxygen delivered to all of those cells in our body so that the cells can make energy. And what delivers the oxygen throughout the body?
Red blood cells.
Red blood cells.
Red blood cells that are, of course, in the blood. So yes, blood is going to transport the red blood cells, and it's the red blood cell that carries that oxygen. And a red blood cell is a mature, let me rephrase that, a mature red blood cell is known as an erythrocyte. And I think I touched on that last week. An erythrocyte. Erythro means red, cyto means cell. A mature red blood cell is called an erythrocyte. Does a mature red blood cell have a nucleus? Shake your head no.
No.
Start to shake your head no. Keep shaking your head no. No, it does not. No. Does it have mitochondria?
Yes.
No. Does not have mitochondria either. And the reason for that is because, remember, we want to get as many seats on that bus as possible. So we get rid of all that stuff. The red blood cell uses a different pathway to make energy. So because it doesn't have a nucleus and it uses this weaker pathway to make energy that I call the backup generator, how long is the lifespan of a red blood cell on average?
120 days.
120 days. Good. All right. So we breathe to get the oxygen that we can deliver throughout the body. The red blood cells do that delivery. The red blood cells are going to take that oxygen, fill up all their seats, deliver it throughout the body. And how much oxygen is in this air that we're breathing in? This atmospheric air. Do you know? Have I told you? Just under 21%. Yeah, just under 21%. So the air that you're breathing in is not 100% oxygen. If it was, the earth would have blown up a long time ago because oxygen is really flammable. So the air that you breathe in is only just under 21% oxygen. So when you take a deep breath in, that's what you're getting. When you breathe back out again, there's just under 17% oxygen in that breath that you're releasing. So you're only taking a small portion of that. By the way, nitrogen makes up the majority of what you're breathing in. Just under 79% is nitrogen. So mostly what you're breathing in is nitrogen and oxygen, mostly. All right, good. So we are going to move into the slides then, if you are ready. Does anyone have any questions before we get started? Yes, no, maybe so. All right. Well then, here we go. You should be able to see my screen in just about now. So there we are. The respiratory system. Respiratory system is going to exchange gases. In other words, we're going to take in the stuff that we want, like that oxygen, and we're going to get rid of the stuff that we don't want, like carbon dioxide. Carbon dioxide is a waste product that our cells create. I talked about that before back in the metabolism lecture. And we get rid of carbon dioxide by breathing it out. We will see later on that carbon dioxide, however, does have another function. We do use it in a very special way in the body. So we'll see that a little bit later on.
I'm sorry, Dr. Surgeon, is this
yes.
chapter 18 we're doing?
Chapter 20.
20, okay.
Yeah. Mm-hmm. The respiratory system filters the air. Of course it does, because the air is filthy. And the inside of the lungs are a very warm and moist environment, which, by the way, is something that, pathogens love. So the inside of the lungs are a warm and moist environment. So we want the air that is going into the lungs to be warm and moist also. So we have the ability to add some moisture if we need to. We have the ability to add some warmth as we breathe the air in. It picks up some of those things, helps bring it in. And then we'll talk about the role of acidity in the blood a little bit later on. The upper respiratory system starting with the nose, then to the throat, the pharynx, and then to the larynx, where we would find the true vocal cords. So you can see the pharynx is divided into 3 different sections. I'm going to jump ahead here. There we are, to this picture, this photo. And I want you to notice something. First of all, of course, the opening to the nose, the nares. Inside of the nasal cavity, there are these 3 bony projections called the nasal turbinates, or I think the book calls them the conchi. And you can see they're simply named superior, middle, and inferior. But I just kind of want you to see that they exist, because as we breathe in, air is going to whip around those and pick up maybe some moisture from the mucous membranes that are there, maybe pick up some heat if it needs to. And then it's going to start to go down. So the pharynx is the throat, and it has 3 parts to it: nasopharynx, oropharynx, and laryngopharynx. Okay, so if I ask most people to point to their throat, most people would point to an area on their neck down around here somewhere. If you can see the person's chin here, they would probably point down around this area and say, well, this is their throat. The reality is the throat is actually way up here. And it ends with the laryngopharynx just below the chin. So let me show you laryngopharynx. And if you follow that line, you can see that it ends right here, which is just below your chin line, almost in line with the just below the hyoid bone. And the nasopharynx starts up here. So the middle of the throat is actually right here. The way to see your pharynx, the middle of your pharynx, is to look in a mirror, open your mouth, stick out your tongue, and say, ah, and look straight back. And in doing so, you would see your oropharynx, the middle of it. And then if you took a dental mirror and stuck it back there, tilted upwards, you'd be able to see the nasopharynx. And if you flipped it around, you'd be able to see down into the laryngopharynx. Oops. So I want people to realize that your throat is actually much higher than most people think that it is. And it's a common pathway because not only is air going down there, but also food and beverages, as you eat and drink something, goes down your throat. But then right here, there's a split. In the front is the air tube, and just posterior to that is the food tube, the esophagus. So you can see the word, the esophagus. That's the food tube.
Question, I'm sorry. When we choke, when the epiglottis or whatever doesn't close, it goes in the air tube then?
Right.
Okay.
Then, and what she's asking about, the epiglottis right here, is this little lid-like structure, looks like this, that flips over the airway here when you swallow something to ensure that food or beverages go down this way. Now, if something makes its way down this tube, this air tube, down here, now we have a serious choking concern. Most of the time, what most people are familiar with is when something just gets to this part right about here, like right in there, and you start coughing, trying to get this stuff out. And that is thankfully not true choking, right? Because true choking, that means that something is blocking the airway and there's not going to be any sound. There's not going to be any coughing. There's not going to be any way to say, help me, I can't breathe, I'm choking, anything like that. But if it catches right about here, that's going to trigger that cough reflex. And I'm sure everybody is familiar with this, where you start coughing, and even after the stuff gets out, even after you've moved it away, it still feels like something is there. It still feels your cough reflex just continues and goes and goes and goes. And realize that that's just the body's response saying, okay, let's make sure we get it out. There might be a little bit of an inflammatory process there that is also going to contribute to that a little bit. But most of the time, when we are eating or drinking, we do not want to have a movement of air. So that epiglottis flips over. When I say that, I want you to hear me. When we are eating or drinking, we do not want a movement of air. So we are holding our breath while we swallow that food and beverage. I say this because if you're trying to do two things at once, like eat and speak, or drink something and speak, you're going to have a hard time. Because remember, in order to say things, in order to speak, there has to be a movement of air through these true vocal cords. So that means air is moving in and out. So don't speak while you're eating or drinking, or else you're going to find yourself choking a lot more and coughing a lot more. So the air goes down into the larynx, the first part there. Oops, let me go this one. And then goes down into the trachea. And the trachea is what most people would refer to as the windpipe. And that kind of makes sense. And we'll see how that branches off a little bit later on. You can see a couple of other things here in this image. Notice how big the tongue is. Most people don't realize their tongue is as big and ugly as it is. And then you can see here some spaces in the bone. Those are called sinuses. And you've probably heard of people having a sinus infection. They're really just hollow areas of the bone. There's a thin mucous membrane in there, but other than that, it's mostly just a hollow space. And the purpose of having hollow areas in bone like this is really just to lighten up the bone. There's no reason to have a huge, thick amount of bone right there. Is that right? A huge, thick amount? Yeah. So it lightens it up. Now, people will say it also changes the tone of voice, like tone of your speech. And that's probably true, but that's not really the purpose of it. It just happens to do that as well. By the way, you can also see right here the sella turcica, that little cutout of the sphenoid bone where the pituitary gland sits. So if you're trying to make sense, remember we were talking about the endocrine system and all these things. If you're trying to imagine where one would find the pituitary gland in that sella turcica, just sort of imagine where your nose is, go just about halfway up, a little more than halfway up, and then straight back. And you can see about where you'd find the pituitary gland. Okay, so let me move back to where we were. The upper respiratory system, as we said, involves the nose, the pharynx, and the larynx. The lower respiratory system is the trachea. We saw that. The bronchial tree. Now, they call it the bronchial tree or sometimes the tracheobronchial tree because it kind of looks like a tree. You can either say all these branches off of the bronchi look like the root system, or if you turned it upside down, it would look like branches off of a tree. So you'll see that in just a little bit. And of course, the lungs. The lungs are huge. They take up most of the space in the thoracic cavity. And they are mainly filled with these tiny little groups of air sacs called alveoli. And these really tiny, thin little air sacs, they're literally one cell layer thick, are going to be full of air. So most of the inside of your lungs is just air, these little sacs full of air. That's why on an X-ray, what you see is a lot of dark area in the lung space because it's mostly air. And then we'll talk about some of these other ones, but an important part, an important thing that is involved in all this is the diaphragm. You'll recall that the diaphragm is that dome-shaped structure that separates the thoracic cavity from the abdominal cavity. And when that dome-shaped structure contracts, when the diaphragm contracts, it's going to shorten because that's what muscles do. And it's going to become less dome-shaped. People will say it flattens out. Well, it doesn't really completely flatten out. It just goes from being very dome-shaped to less dome-shaped. So somewhat flatter. But what that's going to do, that's going to change the air pressure, inside of the lungs. It's going to make the air pressure in the lungs less than the air pressure in the outside world. So air is going to go rushing into the lungs. Literally the opposite of what happens when you blow up a balloon. When you blow up a balloon, you create higher pressure inside the balloon as compared to outside, because of course you're pushing that air into that elastic space. So the air wants to get out. So as you blow up that balloon, if you release it, the air goes rushing out of it because the air pressure inside is higher than the air pressure outside. When our diaphragm contracts, exactly the opposite is happening. the air pressure inside of our lungs is lower than the outside air. So the air goes rushing into the lungs. And I'll go over that. You'll hear me say this again, probably at least one or two more times as we go through this. The intercostals, we'll talk about how those muscles can help. Okay. We talked about the nose a little bit. Remember, of course, there's going to be mucus there because, well, it's going to be something that is going to help trap particles. I think that's all I want to talk about with that. One of the bones that I mentioned, well, I did mention the ethmoid bone as well, but one of the bones I mentioned in the bone anatomy section was the vomer, the little plow-shaped bone that sort of helps make up the wall in the center of the nose. And it is called the vomer because vomer is a Latin word that means plow. So once again, as people were going through naming these bones, they looked at this bone and they said, that bone looks like a plow. It's shaped like a plow. Let's call it the plow. That's exactly what they did. Yet another instance where all you have to do is speak ancient Greek or Latin, and this stuff becomes easy. The nasal septum, oh, that's a wall, right? A septum is a wall. And you can see the vomer here. They're showing us one nostril, basically. So that sort of beige colored bone, the vomer. And you can see how much cartilage in the light blue, and then the nasal bone sort of above it, the two nasal bones above it. We talked about the ethmoid bone a little bit, so I'm not going to go into more of that. The maxilla, of course, you know, palatine is part of that, which makes up the hard palate. The roof of the mouth, the bony part of the mouth. Okay. We saw that. Talked about the nares, talked about the pharynx. Okay. I'm going to talk about the ciliated cells in just a little bit, because cilia are projections of the cell that resemble little hairs. They look like hairs or tiny little fingers coming from the cells, and they are actually all part of the cell. It's all cell membrane, but their job is to sweep, and they sweep things, in this case, in an upward direction. So we'll see that in just a little bit. Okay, so that's a lot about the nose. The pharynx, the throat, tube-like structure. Remember, it is it shares its duties, I should say, with the gastrointestinal system as you eat or drink something. It is a shared passageway so that we can get the food and beverages down to where we need to get them as well. Divide into these three parts. Again, it's easy to remember, just the oropharynx is in the middle, naso is above it, laryngo is below it. And that's what you need to know about that. Okay, I think. Oh, yeah, this I do want to add, I'm sorry. Something that we would see, if you look inside an ear, you'll notice that it dead ends. There is something called the tympanic membrane, or what people would call the eardrum. So the external ear comes to a dead end. And then just on the other side of that membrane are the three smallest bones in the body, the malleus, the incus, and the stapes, or sometimes called the ossicles or the ossicular chain. However, there's also from the middle ear something called the Eustachian Tube. And this tube actually goes from the middle ear down to the throat. And let me go into, where are we here? Very quickly. The Eustachian tube on children is, try again, is short and horizontal, or more horizontal. The Eustachian tube on adults is longer and more vertical. So here's the middle ear. ME stands for middle ear. Middle ear. Here's the pharynx, or the throat. So what does that mean? What does that mean to you? Why do you care that there's this little tiny tube that goes from the throat to the middle ear, from the middle ear to the throat?
Because
Well,
they're more prone to infections.
Oh, absolutely. Imagine all those little pathogens that are in the nose and the mouth and the throat in both adults and children. But look at that short little journey those things have to make to get into the middle ear and cause an infection.
Can I ask a question? Does the shape of, or does how short the Eustachian tube have anything to do with, like, when doctors say don't lay babies down while they're like drinking?
That could absolutely have a little bit to do with it,
Okay.
but it's more likely about making sure that it's not moving down into the airway. They don't have the same type of control. Their body's still learning a lot of control, which again is like why they can't walk for a while. Their body's learning how to control things, I should say. And when you think about swallowing something, the first third, the top third of your esophagus, the food tube, is under voluntary control. So you have to think about swallowing something in order to swallow. And then after that, the rest of the body takes over. So when that stuff goes down into the stomach, and the stomach is also still learning, and it's going to learn when it's had enough and when to stop. And sometimes babies, they might overdo it a little bit. So when they burp, or maybe their stomach says, you know what, we've had enough, then things can go backwards, which means they can make their way up to that split and end up going down into the throat. So there's a couple of reasons why we really would rather have them not lying down, because we don't want them to aspirate those things, whether it's because they didn't swallow it well, or they're trying to breathe at the same time, or because they burped, or there's a little bit of reflux. We want that stuff to actually come out. Going up into the ear, into the Eustachian tube, I'm not going to say that's not a concern, because absolutely we can see why that might be a little bit of a concern. Obviously, it's not going to cause them to choke or drown or something like that, but it could increase the likelihood of infection. You know, if those particles remain in that tube, well, then that's just fuel for bacteria. So I'm going to put that on the list. That's a really good question. But the big problem is about stuff going down the wrong pipe. We don't want them to choke, whether it's as they're drinking it or whether it's as a result of refluxing it. We don't want that to happen. Good question, though. So you can see now with the adult, because of that longer, more vertical Eustachian tube, there's much less threat of infection getting into that middle ear, which is why when kids have ear infections, it's usually otitis media in the middle ear. When adults have ear infections, it's usually otitis externa in the outer ear, in the, more towards the outside, what people would call swimmer's ear. Not that kids can't get that too, because kids like to stick things in their ears. But when a kid does have an ear infection, it's usually in that middle ear. Now, realize that if there's an infection in that middle ear, that's going to be followed by inflammation, and fluid follows inflammation. There's going to be edema, which is going to put pressure on that tympanic membrane, on that eardrum. And so when we're looking in that kid's ear, we can actually see the tympanic membrane kind of bulging a little bit. If this happens a lot, the doctors might suggest putting in a tube. So they cut through the tympanic membrane and they put in this tube that is going to allow the fluid to drain out. Now, I drew it like a long tube. It really is not a long tube. It's actually more, it looks more like a donut. It's really, really, really short. It just fits into the small incision in the tympanic membrane. But that's the idea. And you've probably heard about this before. You probably heard about kids having to get tubes in their ears. It's because they get excessive infections in their middle ear. So, got off topic a little bit, but it's good things to know, just obviously for life. This is why kids get those ear infections so often. I mean, think about it. When was the last time you heard your 22 or 23-year-old friend have an ear infection? Probably never. Well, at least not, you've not heard of them saying they have an ear infection. But when was the last time your child or your friend's child or your niece or nephew had an ear infection, especially those toddlers? They either have an ear infection right now, they just got over an ear infection, or they're about to get an ear infection. That's kind of how they live the first couple of years of their life. So very, very common. I know I'm exaggerating a little bit, but you get the idea. So again, that's the eustachian area, the Eustachian tube. All right, I'm going to skip over this for a minute, so I'm going to show you. Oh, I thought they had that here in a picture. I guess not. Okay. Well, then I won't skip over it. I'll show you. I'll talk about it now, and then we'll see it a little bit later on. Tonsils. You've probably heard of these before. What you might not have known is that there's more than a couple of them. The ones that usually cause the problems and are usually removed are the Palatine tonsils. These are the ones when somebody says they had to have their tonsils taken out, they usually have those removed. And then they'll probably say something like, they also took out the adenoids, which are really just another type of tonsils, the pharyngeal tonsils. And they're located sort of above and behind the Palatine tonsils a little bit. So it's easy if a person has tonsils and they open their mouth, say, every time you say, you can see them off to the sides near the throat, but you can't quite see the adenoids. They're a little more difficult. And tonsils do have an important role in the immune system, helping to clear out pathogens and unwanted things. However, they can sometimes become more of a problem than they're worth if they keep getting infected over and over again. And then they're just removed. It used to be a very common practice back when I was growing up in the 1930s. Everyone my age, by 5 years old, had had their tonsils taken out, because it was just a very common practice. But we've learned in medicine, it's always better to keep all of your original parts if you can. So now it's less common in younger children. They usually only have them taken out if they become a problem into their teen years. The lingual tonsils, these are ones that you've not heard of, because these are ones that usually don't cause a problem. So they don't usually aren't involved in something that's going to come out. So FYI. The larynx. The larynx, this is where we find the true vocal cords. These are the things that make, sound. You can see where it connects here, the larynx. Oh, you can also see a good description of the pharynx as well. You can kind of see where it begins and where it ends. The throat, that is. After the larynx comes the trachea. The trachea is this long tube that extends down through the thoracic cavity and then branches off into two tubes called the right bronchus and left bronchus. You'll sometimes hear them called the right main stem bronchus and left main stem bronchus, or primary. Plural is bronchi, you can see there. And then as they go into the lungs, as they enter the lungs, they branch off into much smaller bronchioles, which will eventually end in these clusters of air sacs called alveoli. And we'll see that in just a little bit. And then, of course, beneath the lungs, you can see the muscular diaphragm, that dome-shaped muscle that is going to flatten out and cause air to come rushing in. This image. Okay. Here we can see, let's go to the front view first. You'll remember the hyoid bone, an attachment site for the tongue. It also attaches to the thyroid ligament. The hyoid bone is the only bone in the body that does not articulate with another bone. In criminal pathology, they will say that this is the bone that is broken when someone is strangled, or I shouldn't say it is often broken when someone is strangled. So they kind of look for that. Then this area called the thyroid cartilage, you will hear me call it the laryngeal cartilage because it does surround the larynx. And right in the center of it is this protrusion coming out towards you. That is the laryngeal prominence, which is what people call the Adam's apple. Everyone has this. It's just much more prominent in men. Below that, the cricothyroid ligament. I point this out because you've probably seen in some movie or television show a person who had some kind of obstruction, breathing disorder where they couldn't get air into their lungs, and somebody had to make an emergency incision, and then they use like a pen or a straw or something and they put it in that hole to allow air to get in so the person can breathe. So this is where that occurs. That cricothyroidectomy occurs right there. That's not a tracheotomy. A tracheotomy is more permanent and it's lower. This is an emergency incision. Very simple to do. All you gotta do is you find that laryngeal prominence, put your finger right below it, just slide your finger right below it, and you can feel this little gap right here between the cricoid cartilage. There we are. Between the cricoid cartilage and the laryngeal cartilage, you can feel that little depression. So it's an easy landmark to find. And then it's a small little incision. Turn the scalpel blade around, just put it in, twist a little bit, and stick a tube in there, and you have an open airway. So if you've ever seen them do that on TV, this is the area that they cut for that emergency. And they have the shadow of the thyroid here, which is nice. It kind of shows you where that's located as well. Turning it around, you can see the epiglottis. That's that lid-like structure that's going to flip over. So when you swallow food or beverages. And another nice thing that it shows here on the posterior aspect of the thyroid are the parathyroid glands. Remember, there are typically 4 of them, these dots of tissue that release parathyroid hormone. Okay, yeah, that's enough of that. So, something I spoke about earlier, now that we're getting into the trachea as well, are cilia. And cilia are projections of cell membrane that look like little hairs or little fingers. In this case, they're going to be oriented in this direction. And there's actually a really good micrograph of it here. We'll see in just a little bit. What do they do? What is the purpose of cilia? Cilia, it's an A, cilia sweep. There is machinery in here there's machinery that runs the length up into these little projections. And that machinery is going to cause them to move. And in this case, in an upward direction, they're going to sweep. Now, why? What's the purpose of sweeping up? Remember, we make mucus to trap things like pathogens, for instance. But once the mucus traps these pathogens, what comes next? We want to get rid of them. So that mucus with those trapped pathogens gets swept upwards until it gets to the point to where we can either cough it out, or you might not like this one as much, swallow it. And why are we swallowing this mucus with all these trapped pathogens? Well, if we swallow it, where's it going to go? That's right. It's going to go into our stomach. And what is in our stomach?
Acid?
There it is, acid. And what's the acid going to do to those pathogens?
Destroy them. Destroy them.
Completely destroy them. Exactly. So, as gross as it might sound, here's the truth. All day long, you are swallowing mucus with trapped pathogens. And that stuff goes into the stomach and gets destroyed. It's important that we have mucus to trap these things, but it's also important that we get that mucus with those trapped things out. Because otherwise, what do we end up with? We end up with a lot of bacteria that are hanging out in a warm and moist environment, which is kind of what they want, which of course then can become an infection. So not only do we want to create the mucus to trap them, we also want to have a mechanism to move that mucus up and out. And that's what cilia do. These projections of the cell membrane, the cilia, they're going to sweep. And they sweep, in this case, in an upward direction to where we can get it to the point we can cough it out or swallow it. Now, do we have cilia in other places in the body? Yes. And in fact, we'll talk about one of those places in the weeks to come. For instance, in the fallopian tubes, those are the tubes that move the ova, the egg, from the ovary down to the uterus. And there's muscle in the walls of those tubes that help propel that egg towards the uterus. But there's also cells that have cilia. They're going to help sweep that egg down towards that uterus. Both those things the sperm have to work against in order to get to the egg, by the way. Okay. So we saw the trachea. And the trachea is this tube, air is going to go down, and of course it's going to branch off into two tubes. And if we look at the trachea from the side, the esophagus, dang it, the esophagus is right behind it. The esophagus is a flattened muscular tube that is going to bring food down to the stomach. So, looking at the trachea, one thing you will notice is that the trachea has C-shaped rings of cartilage around the front of it, the anterior and to the side of it. Those rings of cartilage do not go all the way around the trachea. And there's a reason for this. First of all, why are these rings of cartilage on the trachea? Well, have you ever tried to drink a really thick milkshake through a straw?
Mm.
If you tried it and it doesn't make it all the way up to the top, but you really want that milkshake, and you suck all the air out of the straw, what happens to the straw? It'll collapse, right? It gets sucked in. That's because you've changed the air pressure. You've lowered the air pressure inside of the straw compared to the outside air pressure, and it collapses under that strain. So because we are breathing in and breathing out and breathing in and breathing out and breathing in and breathing out, there's this change of air pressure that is going in and out through this tube and into our lungs. So what we don't want to happen is we don't want that tube to collapse. So we have to have these rings of cartilage around it to stabilize it, so it doesn't just collapse like that straw. The question would be, well, wouldn't it be better then to have cartilage all the way around it? Wouldn't that work better to stabilize it? Well, here's the problem. Dang it. When we eat or drink something, it goes down that food tube, the esophagus, which is directly behind the trachea. So the posterior part of the trachea has to have some give. It has to be a little flexible to allow for that esophagus to expand as you swallow something. And I may have exaggerated the amount that it flexes, but you get the idea. So as you eat something and you swallow it, it goes down here and it moves its way down. That bolus of food here is going to cause this normally flattened muscular tube, the esophagus, to expand. So it is really important to realize that the trachea has this cartilage, but the cartilage is only around the front of it. It is C-shaped. As the trachea descends, we look at it from the front. It branches off into these right and left bronchi. And I tried to make this a little bit exaggerated here. I guess that was close. I just messed it up even more. The bronchi have rings of cartilage all the way around because they don't have to worry about the esophagus behind it. So they're going to have complete rings of cartilage all the way around them. And hopefully you can kind of see here, I tried to show you that the right bronchus is a little more straight up and down. The left bronchus is angled more. The reason for that, of course, is because the heart is going to take up some of that space a little towards the left side. So that left bronchus has to be angled a little bit more that way. And what that means in pathology is that if a child is playing with a toy and aspirates that toy, it's more likely to go the straight route and more likely to go down the right bronchus rather than the left, only because it's a little more straight up and down. That's fun. Okay, maybe just for me. The trachea, or the windpipe, goes from the larynx, branches off into those two bronchi. Trachea is composed of C-shaped cartilage. C-shaped cartilage. You can see this. This is the posterior part right here of the trachea. And you can see how the cartilage in the front comes around to the back, and then there's a space. And that allows for that esophagus to expand. And if you look here, this is a really nice micrograph. Look at those little tiny cilia that look like hairs sticking out. But remember, they're not hairs. This is actually part of the cell membrane with machinery inside, and they are going to be sweeping. Goblet cell, by the way, is a mucus-producing cell. They're showing actually a layer of mucus on top of that cilia. Remember, the cilia is just going to be there to help move things, sweep things in a direction. Good stuff to know. As you can see, the lungs take up most of the space in the thoracic cavity. Remember, they are protected by those ribs, the bones of the sternum, and you can kind of see it here. You'll see it in another image, but you can kind of see it here. The right lung has 1, 2, 3 lobes to it, 3 parts. The left lung only has 1, 2 parts. So the right lung is larger than the left lung. And the reason, again, is because the heart takes up some of the space right here where there would be, well, more lung. So the right lung is larger. It has 3 lobes. The left lung has 2. We talked about the bronchi. Okay, let me show you. Oh. You can see it a little more clearly here. If you look at the right lung, right superior lobe, right middle lobe, right inferior lobe, 3 lobes, left, just the 2. And I'm going to jump ahead just for a moment because I want you to see this part. So all those little branches of the bronchi, the bronchioles, are going to end in these terminal bronchioles, which end in what look like clusters of grapes. But they are not clusters of grapes. These are alveoli, or singular alveolus. This is the end of the line. These are where the oxygen and carbon dioxide exchange actually takes place. These little air sacs are literally 1 cell lining thick. And oxygen is going to easily just move right across those membranes. Carbon dioxide is easily going to move across, strictly based on concentration gradient. Remember diffusion? If you put more particles on one side of a membrane than the other, as long as they can get through, they're going to move from where they are plentiful to where they are less. So we'll come back and talk about alveoli in just a little bit. So I should take a break right now, and we'll come back in just a minute. But before I take a break, I just want to remind you, if you're looking for a t-shirt, guys, all right, Gotta have fun. All right, I'll see you in just a minute. Okay, so we're back. It was just a second ago when I said we're taking a break, but now I'm back. So let's get back to the respiratory system. Talk about some of those things. We talked about the cilia, which is really important. You'll hear me talk about cilia again. Like I said, cilia sweep. Remember, they're going to sweep. They're going to cause some kind of movement. And talked a lot about mucus. Talked about the different pathways. Let's talk about the actual exchange, meaning carbon dioxide and oxygen exchange. So let's see what that looks like. And I'll show you here as soon as you can see my screen, which should be right about now. All right, let's get rid of this. So here we have one of those air sacs, an alveolus. So air, as we breathe in, is coming in. Now, again, these are coming clusters, so there's lots of them, but I'm just going to demonstrate one just to make it simple. And we are going to have capillaries that sit right on top. Now I'm leaving a little bit of a space. I should have made it a little bit bigger. I'm leaving a little bit of a space because there is a membrane in between, but this is blood coming from the right side of the heart, meaning it is low in oxygen. We'll say it is deoxygenated, but please remember that that does not mean zero oxygen. That just means less oxygen. And now we have the blood going back to, oops, not the right, back to the left side of the heart, left side of the heart. This blood is going to be full of oxygen. And of course, we're going to have our red blood cells coming through. This is a capillary, so they're coming through single file. Remember, the capillaries are the smallest of the blood vessels. Those red blood cells, as they're coming through, are going to have low oxygen. I'm just going to put a couple of dots of oxygen in there, because the air that we breathe in has just under 21% oxygen. That oxygen is going to move across these membranes and into these red blood cells and completely fill every seat on that red blood cell bus. So when these red blood cells return to the left side of the heart, they are full of oxygen. Blood coming from the right side of the heart is low in oxygen. We say it is deoxygenated. Blood going to the left side of the heart is going to be full of oxygen. It is oxygenated blood. So the whole left side of the heart is full of oxygenated blood. The whole right side of the heart is full of deoxygenated blood. And remember, that does not mean zero oxygen. It means low in oxygen. Meanwhile, we have carbon dioxide in our blood. This is a waste product that we've created. And that carbon dioxide is going to move from the blood into the alveoli. All of this movement is going to happen because of diffusion. Yeah, I'll use red just for fun. Remember, if we have a membrane and we have a whole lot of particles on one side of the membrane, and less particles on the other, as long as those particles can move across, they're going to move with their concentration gradient from where they are plentiful to where they are less plentiful until the concentrations are the same. Simple diffusion. So we breathe this air in. The air that we breathe in has just under 21% oxygen. That oxygen is going to go across those membranes. So it's going to cross the membrane of the alveolus, it's going to cross the connecting membrane, it's going to cross the membrane of the capillary, and even cross the membrane of the red blood cell. And it's going to do that simply because there's more oxygen on this side of the membrane than there is on this side of the membrane. Simple diffusion. And it's going to take a seat, fill up all those seats on all those red blood cell buses. Meanwhile, carbon dioxide is going to move out of the blood across the membrane of the capillary, across that connecting membrane, and across the membrane of the alveolus. And carbon dioxide is going to do that simply because of diffusion. Now, you'll notice I didn't put carbon dioxide on the red blood cells. And that's because most carbon dioxide actually travels in the blood. But it travels in the blood. Oh, shoot. Already. It travels in the blood as bicarbonate. So most carbon dioxide is in the blood, oops, HCO3 minus, as bicarbonate, HCO3 minus. And when it gets to this area in the lungs, it'll convert back to carbon dioxide, and it'll cross the membranes and we can breathe it out. So does carbon dioxide get on those red blood cell buses? A little bit. But the way I want you to remember it, because more than 2/3 of it, almost 75% of it, 70 to 75%, travels in the blood as bicarbonate, HCO3 minus. And that is important because bicarbonate is the most powerful buffer that we have in our blood. The pH of our blood is right around 7.4, approximately 7.4. If it becomes too acidic, in other words, if that number goes lower, remember a lower pH means more acidic, then bicarbonate will help out and raise the pH back to where we want it to be. So even though we make carbon dioxide over here, even though we make carbon dioxide as a waste product, we do utilize it in helping to buffer the blood. Most of it is going to travel in the blood as bicarbonate. And then when it gets to the lungs, it converts back to carbon dioxide and we breathe it out. Stuff to know. Okay, alveoli are made up of single layers of simple squamous epithelial tissue. Simple means one layer. Squamous, kind of flat, squarish. Epithelial, remember epithelial means a lining or some sort of covering. We talked about that way back in, I think, week 1 or 2. Allows those molecules to move across. Then there is something called surfactant. Surfactant is going to help keep those alveoli, those little balloon-like sacs, from collapsing. Helps to keep surface tension so that they don't collapse. Now, why do I bring this up? When a woman is pregnant and that baby is developing into that late second trimester, into the second trimester, around week 23, 24, the baby's lungs start making the surfactant. And it's usually by about week 26, the baby has surfactant enough. But I say this because if we try to deliver that baby before the baby's lungs are making surfactant, the baby will not survive. This is the last thing that has to occur in order for the baby to survive in our world. Because if there isn't surfactant being created, as soon as that baby comes out and the cord is cut, that baby takes a breath in our world and then breathes out. That's it. That's the last breath that baby will ever get. Everything will collapse and the baby will die. There's no way to fix that. So this is the last thing that has to happen. The baby has to be making enough surfactant in order for it to be able to survive in our world. Now, we know the brain is still developing long after the baby's born even. We know that even the eyes, even though the eyes started to develop in the first trimester, they don't finish developing until the third trimester. So we know that if we deliver this baby early, there's the potential that the brain might not develop completely or the eyes might not develop completely, but it can at least survive. The baby would still be able to survive in the world. However, if there's not enough surfactant, then the baby will not survive. So how the doctor will describe this is the doctor will say the baby's lungs aren't fully developed yet. Well, it makes it sound like, yeah.
I'm sorry to interrupt you. You're saying if it's not enough, what, the baby won't survive?
Surfactant. Surfactant.
Sir, how do you know if the baby accumulated enough surfactant or not? How would you know? How would you know?
Well, partially by the time period. And then we can even give mom something that will help the baby create more surfactant. But after that, it would be difficult to realize.
What's the time period for the baby to develop enough surfactant?
Between 22 and 26 weeks. So even if a baby is delivered, then you'll find that the doctor had to give mom something to make sure the baby creates this. It's a lecithin sphygmomyelin, by the way, combination of protein and fat. And as I said, the doctor will describe it as the lungs not being fully developed. But that does not mean that they're not like built, that the lungs aren't complete in their size. It just means that the cells in their lungs, there's specialized cells in those alveoli that make the surfactant. And that's what they mean. That it's just not making enough surfactant yet. Too risky. So they'll describe it that way, but just so you understand, it's not that the lungs aren't like built. It's just that they're not creating this, or at least not enough. You can see the lungs here. We'll look at the drawing first. As I said, the right lung is larger than the left lung. The right lung has 3 lobes. The left lung has 2. The lungs have a base at the bottom, and the pointed part near the top is referred to as the apex, which is a little bit different than the heart. You'll remember the heart has a pointed part near the bottom, referred to as the apex. So the apex of the lungs is actually at the top. There's an indented area called a hilum, and we'll see this again on other organs like the kidneys. A hilum is an indented area where everything either moves into or comes out of an organ, the hilum. And in this image here, you can see the trachea, here. As it branches off, you can clearly see the left bronchus. You can't quite as clearly see the right bronchus, but you can see the right pulmonary artery. Remember, this is coming from the right side of the heart, and it is delivering blood that is low in oxygen. And then below that, you can see the two pulmonary veins that are going to bring that blood back to the left side of the heart, which of course, that blood is going to hopefully be full of oxygen. When we talked about the heart, I said that the heart has a lining around it, a double layer membrane around it called the pericardium. And I said that the heart has a visceral pericardium that is in contact with the heart. And then the outer layer is called the parietal pericardium. And in between there is fluid called pericardial fluid. So as the heart expands and contracts, it is not going to rub up against things and create friction, because one thing the body does not like is friction. And then after describing this on the heart, I said, it's an important concept because we will see other organs also have a double layer membrane. And here in the lungs, we will see this as well. The lungs have a double layer membrane called the pleura. And the most important parts, the two most important parts, is the visceral pleura, the part that is in contact with the lungs, and then the outer part, the parietal pleura. And then in between, again, there's going to be fluid that's going to allow for these to glide across one another, and that is called the pleural fluid. Pretty simple that way. So we're not going to worry about the three divisions. The thorax, or the thorax is the chest area. The thoracic cavity is the place, of course, where we find the lungs. Inspiration is breathing in, expiration is breathing out. And now let me start by going ahead quite a bit. I don't know why they put it so far ahead, but it's a really good image. Remember I said earlier, we started this conversation, and I said that I could put a wire up your nose, go through the back of your nose, down into your throat, your pharynx, down to the larynx, down to the trachea, down to the bronchi, to the bronchioles, all the way down to the alveoli, without going through a single membrane or going through a single doorway. So those areas are still continuous with the outside world. So what this is showing you here, it's showing all of those areas are still considered external. Even though you think of something that is in your windpipe, in your trachea, you think of that as internal. Technically, it's still external environment. And you think of things in your nasal cavity as being internal. Technically, it's still external environment. And it doesn't become internal until we have things crossing membranes, like we see here. Oxygen, molecular oxygen crossing the membranes, moving into the cells, carbon dioxide moving out across those membranes, back into this. So this is a diagram that I would have started with. This is something that I would have put in the front of the book, just so that people will get the understanding that these are still areas that are technically not inside of your body. All right, so going back to, way back to here. External and internal respiration. So what's the difference? Well, internal respiration is when molecules cross a membrane. like I just showed you, oxygen, carbon dioxide. What that means is everything else is external. It's only considered internal when it's crossing a membrane. Everything else is considered external respiration. So even like think about air going into your nasal cavity, that's still external. Going into your trachea, that's still external. It doesn't count as internal until something like this happens. It crosses a membrane. So what they're showing you here again, the alveoli. Remember, these capillaries would be in like sitting almost right on top of these alveoli. There'd just be a small little connecting membrane between them, because there'd have to be. Notice how the blood that is full of oxygen is returning to the left side of the heart. So all of the chambers on the left side of the heart, the left atrium and left ventricle, are full of blood that's full of oxygen. That left atrium collects that blood, pumps it down through the bicuspid or the mitral valve. The left ventricle then pumps that blood up and out at just under 200 miles per hour into the aorta, through that aortic valve into the aorta. Blood on the right side of the heart is deoxygenated. That does not mean zero oxygen. That means it's low in oxygen. So all the blood in the body that has already dropped off a bunch of oxygen has to return back to the right side of the heart, goes into the right atrium, gets pumped straight down into that right ventricle, going through the tricuspid valve. And then from the right ventricle, it gets pumped up through the pulmonary valve into the pulmonary trunk, the pulmonary arteries, and over to the lungs. So when you're thinking about those valves between the right atrium, right ventricle, left atrium, left ventricle, the tricuspid is on the right side. The bicuspid, also known as the mitral valve, is on the left side. So you try before you buy.
Before you buy.
Wait, what?
I was just saying try before you buy.
Yes, that's a way a lot of people use to remember which one's the tricuspid and which one's the bicuspid. On the right side, tricuspid, left side, bicuspid. Don't forget though, the bicuspid is also known as the mitral valve. So you'll see those terms used interchangeably, bicuspid and mitral valve. What this is also demonstrating here are that there are areas that are going to be able to sense things like how much of these gases there are in your blood and send those signals back to your brain stem, which is going to make determinations as to if we should breathe more or if we should breathe less. And you'll even notice they're showing a motor output to respiratory muscles. Well, that diaphragm, that is one big respiratory muscle. And remember, in order for a muscle to contract, it needs to be told to contract. And the thing that tells muscles to contract is a nerve. So in this case, for the diaphragm, the nerve is going to be the phrenic nerve, spelled with a PH. Let me write that down real quick, just so I don't forget to include it here. The phrenic nerve. Innervates the diaphragm. The phrenic nerve, phrenic with a PH. phrenic nerve, phrenic with a PH. The phrenic nerve. I think you might see that come up somewhere in the future. The phrenic nerve. Okay. Look at the term. Yes.
What do you mean by innervates the what innervate?
Remember what I said. In order for a muscle to contract, it needs to be told to contract. And the thing that tells a muscle to contract is a nerve. So the nerve that sends the signal, that's the innervate part, the nerve that sends the signal to the diaphragm is called the phrenic nerve.
Okay.
The phrenic nerve, spelled with a PH. Phrenic. Okay, where was I? Pulmonary ventilation. Ventilation. You probably heard this word before some point in your life. Maybe you were painting something and on the label it read, or maybe cleaning something, and it read, using a well-ventilated area. And what did that mean? It means, of course, that you want a movement of air. You want the ability for bad air to leave and good air to come in. So when we talk about ventilation, that's what we mean. Bad air leaving, good air coming in. And of course, we are going to do this by breathing. All right, talked a little bit about the changes in the air pressure. One inspiration and one expiration equals one respiration. Breathing in is inspiration, breathing out is expiration. Breathing in, that's the active part. Breathing out is passive. And the thoracic cavity will change its shape in 3 different directions: height and width and depth. What they're showing you here, this is a very common comparison when talking about the thoracic cavity. Remember, the thoracic cavity is bordered laterally by those ribs. Well, the ribs start out in the back. The ribs start out on those thoracic vertebrae, and as they come around towards the front, they actually swoop downward. But when we breathe, the ribs have the ability to elevate. And the way that is often described is the ribs elevate the way a handle on a bucket would elevate, that same sort of motion. The bones of the sternum, they actually, in the front of the thoracic cavity, elevates a little bit differently. It's more like a handle to a pump on a well, like those wells that you used to see on farms where they have to pump water out. That sort of motion is how the front of the thoracic cavity operates. And here they're showing how the lungs fill up the thoracic cavity. And as you breathe out, the lungs no longer fill up that whole space. So this whole process starts here with the diaphragm contracting. Remember, the phrenic nerve is going to tell that diaphragm to contract. And it is going to go from being dome-shaped to less dome-shaped. That is going to change the air pressure. So the inside of the lungs has now a lower air pressure than the outside. So air is going to come rushing in. And you can see in some instances, we can use these other muscles as well, these accessory muscles, including the sternocleidomastoid, to help cause this air to come rushing in. especially if you want to take a really deep breath. Where are we on time? Okay. Where are we on the slides? Okay. Breathing out occurs when the diaphragm simply relaxes. That's why I say this is a passive process. Now, if we want to force more air out, then we can contract some of these muscles, a lot of these intercostal muscles, and the abdominal muscles, and force air out. Now, let's think about that for a moment. When do you force air out of your lungs? How about when you cough? Because in order to get things out that we don't want in our lungs, like particles or pathogens or dust or whatever, we want to forcefully remove them. And that's what a cough is. It is a forceful expiration. You're forcefully exhaling, combining two words into one. You forcefully exhale. That is a cough. But that means it requires a lot of these other muscles to do that. So if you've ever had an upper respiratory infection where you were coughing for 3 days straight, it just seemed like all you were doing was coughing, 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 coughing. And you go to the doctors and you're describing how you're coughing and there's yellow stuff coming up and you have a fever and you don't feel well. And then you say, oh, and my chest hurts. And the doctor says, oh, that's skeletal muscle pain. You're using all those muscles all day long, forcing air out. And they're going to hurt. Okay, we'll go past this to this right here. And actually, we'll stop for a moment. The next stuff coming up will look a little intimidating at first, but I'm going to point out what you definitely want to know about. Because if you try to learn all of it at once, it might get a little confusing. It might get a little overwhelming. It's not really that bad, but I think it's easier if I just focus on about one or two things, and that'll make it a little easier for you. So,
sir, I have a question. I know a person in particular that he has to go back and forth to the hospital to get fluid taken out of his lungs, and he has to do that a lot. Do you know why he was causing the fluid in the lungs?
Unfortunately, I have no idea. I do not know why someone has to go and get fluid taken out of their lungs a lot, because there's different things that can cause that. So I would just be speculating. So I honestly don't know. And if a person has a condition like cystic fibrosis, they are going to be creating a lot of mucus, a lot of really thick mucus, and that can create some big problems throughout their lifetime. That could definitely shorten their lifetime. If a person has if a person has any sort of injury or chronic infection, they're going to have chronic inflammation in their lungs, which of course means chronic edema, and that can certainly be a part of it. But I would need to know where the fluid is. Is it in the alveoli? Is it around the alveoli? Is it between the layers, the pleura?
I don't know.
Those would be questions that would help narrow things down considerably. But otherwise, I couldn't even begin to speculate, in fact.
Thank you.
Yeah, so if you can find out, exactly what's being done, if this is somebody that you know well and they're willing to talk to you about this, ask more questions. Okay, I'm going to be right back, so don't go anywhere. And I am going to stop right now. Okay, so back now, going to get started on this next topic, which, as I said, can be a little bit tricky, but it's easier if you learn sort of one part at a time. Pulmonary volumes. Volumes of air moving in and out when we breathe. The one that I really want you to know about is tidal volume. Now, what do you know about ocean tides? Ocean tides go in and they go out, right? Tides come in, tides go out. So think of it that way. Tidal volume, air going in, air going out. So here it has volume of air exhaled after a normal breath. So it's also going to be about equivalent to the volume of air that you inhale with a normal breath. And it's about 500 milliliters, 400 to 500 milliliters of air. That's a normal tidal volume for an adult. So in other words, as you've been sitting here all morning, enjoying this lecture, learning all this new stuff, you haven't thought about breathing, probably. You haven't thought about breathing for the most part, yet you've been doing it, and probably pretty well. Don't even think about it, you breathe air in. Don't even think about it, you breathe air out. That air that you're breathing in and out that you're not even thinking about, that is your tidal volume. So think of it that way. The air that you breathe in and out that you're not even thinking about, that is what we call our tidal volume. And that is going to be about 400 to 500 milliliters of air. So that's sort of the number that you want to know, about 500 milliliters of air, 400 to 500. The tidal volume. That's the normal amount of air when you're not thinking about breathing, moving in and out of your lungs. So just a good, that's the one of all of these that I want you to know about. So what are all these other things? Well, if you are breathing air in and out, not thinking about it, your tidal volume, after you breathe out that 500 milliliters, pardon me, after you breathe out that 500 milliliters of air, there's still air in your lungs that you could force out if you had to. Force that air out, contracting all those muscles. And you can try this on your own. Just breathe normally, and then after you normally exhale, force more air to come out of your lungs. That is what we call our expiratory reserve volume. And notice it's about 1,000 milliliters. But even after you force all that air out of your lungs, there's still something called the residual volume that you cannot force out, you cannot get out. And you can see that's going to hover around 1,200 milliliters. So I'm not as concerned about those numbers. I'm not as concerned about the expiratory volume. I'm not as concerned about the residual volume. I'm more concerned about the tidal volume, about 500 milliliters. Then, as you are well aware, if I said to you, if you were swimming, for instance, and you're going to dive deep into the water, you're probably going to take a deep breath. You're going to take one big deep breath in. Well, how much, what is that called, first of all, and how much is it? That is called the inspiratory reserve volume. And that's about 3,300 milliliters of air. But again, that one I'm not as concerned about. The one I want you to start out knowing is just the normal amount of air moving in and out of the lungs. If you end up working in pulmonology, with pulmonologists, believe me, you'll learn all these other things. But for right now, that's First one, the best one to know, just normal breathing, tidal volume, about 500 milliliters, 4 to 500 milliliters of air moving in and out. So that's what's represented here. And I know it looks confusing if this is the first time you see it, but just look at this middle part first of all. Here you are just breathing in and out, not even thinking about it. Air moving in, air moving out, air moving in, air moving out, air moving in, air moving out, not even thinking about it. That's this part in the middle. Then after the air moves out, you want to force more air out. That's this one here, expiratory. Then after that, there's air that you'll never be able to force out, and that's the residual. And up top, this is when you take that really big deep breath in, inspiratory. So without moving into any of the other chart, that just gives you a quick overview. And like I said, when it comes to the physiology of breathing, it can get a little complicated, and the gases, the exchange of gases can get a little complicated. So I'm going to just scratch the surface of it. So there's the surface of it. Easiest to know that way. Same with these. When you start adding up all of these things, total lung capacity, that just kind of makes sense. If you add up all that stuff, then it makes sense that that's the maximum that your lungs can hold. Okay. Again, this is just terminology, but this is actually a really good definition of partial pressure. Pressure exerted by a gas in a mixture of something else, usually a gas or a liquid. So you can kind of think of partial pressure as being in concentration. And that helps because remember, we've talked about concentration gradients before, meaning having more of something in an area versus less. So the term partial pressure is one that you'll sometimes hear used, and this is a pretty good definition. So you'll often see it described as PO2, for instance, the pressure. How does blood transport these things around? Well, we know the hemoglobin molecule is the seat on the bus that carries 4 oxygen molecules, that's 4 O2s. So here is an image of the quaternary structure of this protein. Notice there are 2 alpha chains, alpha 1, alpha 2, 2 beta chains, beta 1, beta 2. This is the normal makeup of what we call adult hemoglobin. There is another type of hemoglobin that we'll find in smaller amounts. Alpha 1, alpha 2, delta 1, delta 2. It's a normal hemoglobin, but it's in much, much lower concentrations. And then there's another one we'll find called fetal hemoglobin. Fetal hemoglobin has alpha 1, alpha 2, and gamma 1 and gamma 2. Not surprisingly, fetal hemoglobin is going to be found in babies, well, especially before they're born. Now, do we still make fetal hemoglobin? You would think no. You would say, no, I don't make fetal hemoglobin. I'm an adult. Actually, you do. A very small amount of it. But you do still make some fetal hemoglobin. And why do you care about that? Remember sickle cell anemia? Remember sickle cell anemia causes the red blood cells to become, well, sickle-shaped? And the reason those red blood cells become sickle-shaped is because of the change in the hemoglobin molecule, specifically this part of it, the beta 1 and beta 2 chain. That's the part that is changed in sickle cell patients. And that change in the beta 1 and beta 2 causes a change in the shape of the hemoglobin. Instead of being globe shaped, like this is sort of like roundish shape, it is more stick shaped. And because of that, that changes the shape of the red blood cells, as we noted. So if a person had sickle cell anemia and they had these beta chains that were wrong, what if they had more of the fetal hemoglobin? Because the fetal hemoglobin doesn't have beta chains, it has gamma chains. Would they be able to utilize that? Well, they could actually. And so some of the medications that are used to treat sickle cell patients are actually causing sickle cell patients to make more fetal hemoglobin. It's an interesting idea, interesting how it works. Okay, remember iron is in each of these groups. We talked about that. Gases other than oxygen and carbon dioxide combine to hemoglobin. So first of all, we know oxygen can take a seat in those seats. We know oxygen sits there. But so does carbon dioxide. That's that molecule that we make as a waste product that we want to get rid of. However, most carbon dioxide travels in the blood, not in the red blood cells. So I wouldn't even consider the role of carbon dioxide in the red blood cells. Not yet. I would think more about carbon dioxide's role in the blood. That's more important right now when you're learning this early on. Also nitric oxide in red blood cells, but I'm not going to worry about that one. When you think about red blood cells, I really just want you to imagine those red blood cell buses filled up with oxygen passengers. However, there is another passenger that can sit in those seats, and that's bad. That is carbon monoxide, not CO2. This is CO, carbon monoxide. This is the stuff that comes from car exhausts. This is the stuff that comes from the furnace in the house when it is not properly ventilated. This is the stuff that kills people. So
it can come from the stove too, correctly?
Some stoves, yes.
And then I think it also comes from like the car, when the car is being ran.
Exactly, yes. So what's the problem with carbon monoxide? Carbon monoxide actually binds tighter to hemoglobin than oxygen does. In other words, it takes a seat and doesn't want to move, which means oxygen can't get on the bus. Oxygen can't be delivered. So the person gets less oxygen going to their cells, including their brain cells, which causes them to get tired, pass out, go into a coma, and die. So if a person is in an environment where there's a lot of carbon monoxide, what we want to do is get them out of that environment, first of all, get them into fresh air, and then we're going to administer 100% oxygen. Because remember, the air only has just under 21%. we're going to give them 100% oxygen because we are going to want to kick out that carbon monoxide. We're literally going to bully it out of the seats. Say, there's more of us than there is of you. Get out of here. So if that happens early enough, then the person can survive. This is why it is really important to have carbon monoxide detectors in your home.
So, Dr. Sturgeon, what if you, like, you're living somewhere and there's like a leak of carbon monoxide? Like, are there like, would there be like a slow, like symptoms that happen like gradually prior to you passing out, or like how
Yes.
long does that take?
Yeah, there's definitely all the things leading up to that. Remember, we need oxygen in order to make energy, right? So anytime we're making less energy because we don't have glucose or oxygen or water, everything that cells are supposed to do slows down. So the person is going to be lethargic. They are going to have difficulty thinking, difficult with cognitive abilities. They might feel dizzy, lightheaded. They have muscle weakness. Everything that goes along with a low energy state. And you cannot smell carbon monoxide. You know, it's not
I
like
was going to say, sometimes they say that it's a silent killer.
Yes, that's exactly why. You can't see it, you can't smell it. And you're going to sleep at night, so you're feeling tired anyway. You don't realize, well, now I'm tired, I'm a bit dizzy, I don't feel so great, I'm going to lie down, and that's it. So not most, let me rephrase that. Many modern smoke detectors are a combination smoke detector and carbon monoxide detector. But if you are renting, it is the landlord's duty to have not just smoke detectors, but carbon monoxide detectors as well. So make sure if you're renting someplace right now, make sure you have those in the house. If not, contact your landlord. By law, they have to have them in there. And I mean, they'll want to put them in. They don't want their tenants dying. And they're not that expensive. You could actually get plug-in ones that are $20, I think. I keep one in the basement about 8 feet away from the furnace. I had an extra one there because it's the one that's going to probably detect it first before anything else. And then all my smoke detectors, I think all of them are a combination as well. So it's an important thing to have because it doesn't take much. One little leak of that starts moving into your room or your house, and it can be very dangerous. And you hear about this every year. You hear about a family that dies. But yeah, that was a good point. They call it the silent killer for a reason. We talked a little bit about that already. I'm not going to talk too much about that. I already talked about that. We've talked about the diffusion of oxygen. Talked a little bit about respiratory control centers in the brain, and you can see here a lot of that is happening in the brain stem. They're showing at the carotid bifurcations here. Remember, here's the aorta, off the aorta coming from that left ventricle, and you can see there's 3 big branches at the aortic arch. The coronary branches are the ones that lie on top of the heart. Those are the first 2 main branches, but you can see these 3 big branches off the aortic arch. The first one, as a reminder, is the Brachiocephalic Artery. That Brachiocephalic Artery that's here quickly branches off into the right subclavian and right common carotid artery. They're showing these areas enlarged so that you recognize that there are sensor cells there. And then the second branch is the left common carotid, goes right up. And then the third branch is the left subclavian artery. Just as reminders, because you do have a quiz coming up later on. It's showing that at that bifurcation of those carotid arteries going up the neck, there are receptors of both pressure and chemical that can sense whether or not there's enough blood and enough oxygen going up to the brain or not, and will make adjustments, send information to the brainstem to make adjustments on things like breathing. Should we be breathing more or less? And that's what that says there. Isn't it? Okay. Well, a little bit early. Oops. Okay, so that is the basis of the respiratory system. Like I said, I didn't want to get too much into that, some of that physiology, because it will become overwhelming very quickly. That is better left for a more advanced class. For you guys, trying to comprehend all of that right now could be a little bit complicated and difficult. So I just wanted to give you the overall concept of what is happening when we're breathing in, where that oxygen is going, how it's moving, etc. Anyone have any questions? No. Okay. Then I'm going to stop recording right now. So I'll say goodbye and I'll see you in just a few seconds. Goodbye. Okay, so now that we are back, we are going to start talking about the gastrointestinal system. Let me make sure I've adjusted the camera correctly here so I can, oh yeah, there's the camera correctly adjusted so that you can see the t-shirt. All right. I should go into sales, huh? Start selling t-shirts as a full-time job. Maybe not. All right, so let's get into the gastrointestinal system. And let's start out with an easy question. Why do we eat? And don't say to live, because that was your answer when I asked, why do we breathe? I know you didn't say it, but you thought it.
For
So
fuel.
why do we eat?
To get energy.
Well, how do we get the energy? We make the energy, but what do we get from the food?
Nutrients.
Sugar. Nutrient, sugar.
Yeah, we get the nutrients, things like glucose, right? The
Protein.
main fuel, proteins, absolutely.
Water.
Water, yes. Because we're making two things more than anything else, right? We're making energy and we're making proteins. So if we're making energy, we're going to need glucose, oxygen, and water. And if we're making proteins, we're going to have to take in proteins to break them down so that we can take those amino acid building blocks and build up more proteins again. Good. All right. So now we know why we eat. So how does this happen? Well, let's look at the body in its simplest form, or at least the gastrointestinal system in its simplest form. So you should be able to see my screen in just a moment here. All right, about now, probably. So let's look at the gastrointestinal system. So here it is. If we look at a human being, the gastrointestinal system is really just one long tube that goes all the way through the body. And what do we do with this tube? Well, we take in things like nutrients. In this case, pepperoni pizza. I know you're thinking, well, that's not very nutritious. Well, yeah, you're right. It's not terribly nutritious, but it sure is delicious. So we are going to take in this pizza. And the first thing we're going to do is chomp it up into smaller pieces. So we end up with pieces of a slice of pizza that we're going to move down into our stomach. In our stomach, those pieces are going to get broken down into smaller pieces chemically, a little bit of enzymes in there, and that's going to move into the small intestines where they get broken down into the smallest possible pieces. Now we are going to absorb them. In other words, now this stuff is going to actually move into our cells and into our blood. But what if we ate something that was too big, or we couldn't break it down? If it's too big and we can't break it down, it's just going to continue on through. This is why when that child swallows a dime, it comes out the other end as a dime. It does not come out the other end as a nickel and 5 pennies. It comes out as a dime. If we can't break something down, if we can't absorb it, then it's leftover. And it's just going to keep going through. So if you think of human beings, we are really just this big, long feeding tube that wants to reproduce and make more feeding tubes. Kind of a simple idea, but everything that we've evolved over the millennia, over millions of years, everything that we've evolved so that we could become better feeding tubes. We can reproduce better. We can find food better. We can see food. We can hear other feeding tubes. We can hear the dinner bell.
Yes, sir.
We can move to where the other feeding tubes are, where the food is. Or maybe if something wants to eat us, we can run away. We can reach out and say hello and shake the hand of the other feeding tubes, or we can reach out and grab food. So everything that we've evolved to become better at this, better feeding tubes that can reproduce. So our entire gastrointestinal system is just one long tube that runs through our body. So where does our gastrointestinal system begin? Well, I think it's easy to say it begins with our mouth. But where in our mouth? Well, some people would say the teeth, because the teeth are going to be chomping up this food product to get it to go into smaller pieces so we can swallow it and move it into our stomach. And that is certainly legitimate to say, yeah, the teeth, the gastrointestinal system begins with the teeth. That certainly makes sense. But if you think about a baby, and if you think about a baby breastfeeding, if that baby was born with a congenital defect, like a cleft lip, where there's space, where there should be lip, but there is not, what's going to happen is that baby tries to breastfeed, it's not going to do as well breastfeeding as a child who has full lips. So therefore, having full lips kind of helps in the feeding process and therefore helps to keep the food in. So some people could argue that the lips is going to be the place where the gastrointestinal system begins. And that could certainly is understandable. However, there's some people who will even say it starts before that. It starts in the preparation of food. When we cook things over this brown fire. As we're cooking things, oh, I didn't put a top on the lid, did I? As we're cooking things, we kind of make them easier to eat. So imagine a potato. If you were to go to the grocery store and get a bag of potatoes and take one of the potatoes out and just bite into it, you might find it kind of difficult to bite and chew, which means it's not going to be in the tiny, tiny pieces really as you're digesting it. So a lot of it is going to end up moving through. So you're going to lose some of the nutrients that you otherwise would have been able to absorb, because you can't really break it down as well if it's still big chunky pieces. So some people could argue that digestion actually can even begin as early as the cooking process, the preparation of the food. Okay, there's an argument for that. And the reason I bring this up is because you'll hear people say it's always better to eat fresh fruits and vegetables, because once you cook them, you cook out all the nutrients. Well, that's not really accurate. And there might be some that are lost in the cooking process, but at the same time, you might actually make the food easier to digest. And if it's easier to digest, then you're going to be able to get more nutrients from it. So there's an argument the other way as well. Now, one second, because the one thing that we all agree on is if you're going to eat carrot sticks, if you're going to eat broccoli, once you cover it with blue cheese or ranch dressing or melted cheese or a ton of butter and salt, now you've just created candy, basically. You've taken that piece of vegetable that would have been a really good nutrient, and now you've just coated it with all kind of extra sugars and fats that aren't necessary, and salt, and that's when it becomes a problem. Yes, what is your question? Someone had a question? No question? Okay. People. Feeding tube. Same thing. All right, nobody cares.
Yeah, so what I was going to say in regards to this topic here, when a patient get a feeding tube, is it because those muscles and everything in the esophagus is not contracting or moving properly?
That is certainly the main reason why somebody would have to get a feed, or one of the reasons why someone would have to get a feeding tube. Yes, because that esophagus has to be able to push that bolus of food down. Oops. So there is a word for this called peristalsis, as the muscles in the wall of that esophagus pushes that food stuff down, making the esophagus longer and longer, aren't I? If you cannot do this on your own, if for some reason the body isn't allowing this, then yes, we have to get those nutrients into the stomach somehow.
Doesn't that happen with a lot of people that have MS?
You mean multiple sclerosis?
Yeah.
What's the problem in multiple sclerosis?
It's something dealing with their muscles.
You would think so, right?
Yeah. I think that's why they lose movement and they get impaired.
Okay. Do they have any other issues?
Nerve issues.
Like vision?
Uh-huh.
Yeah. You see, in order for a muscle to contract, what does it need?
The cell that tells it to contract. I forget
Yes.
the name.
If we have a muscle just sitting here and we want it to contract, we have to tell it to contract.
Is it the mature red blood cell?
No.
It's a nerve, right?
The nerve. Remember, the action potential, the electrical signal travels down a nerve. That nerve then releases a neurotransmitter that binds to receptors on the muscle cell membrane, causes sodium to come in. And then we talked about that whole calcium releasing and then the whole sliding filament theory. But in order for a muscle to contract, it has to be told to contract. And that's what a nerve does. It says, hey, contract. Of course, that's an electrical signal. So what if that electrical signal never got down to the muscle? The muscle wouldn't know to contract.
Atrophy, right?
Well,
Like
atrophy of the
muscle
muscle
loss?
will occur, yes.
Okay.
So with MS, multiple sclerosis, because you want to think that the muscles, it involves the muscle, but it actually is a problem happening in the nerve. It's a demyelination. Remember that myelin insulation that goes around the axons?
Yeah, myelin sheath.
Exactly. That myelin sheath gets lost. That's the thing that helps send that signal down the nerve. If that signal goes down the nerve and then finds an area where there's no myelin, the signal will just stop, which means it'll never make it to the muscle, which means the muscle won't know to contract. So how does food move down the esophagus? Well, muscle. There is muscle in the walls of the esophagus that propel food downwards. Well, I should say downwards, towards your stomach. Because if you're hanging upside down by your feet, can you swallow something?
Yeah.
Yeah, I'm not going to recommend that. You should really not be hanging upside down and eating at the same time, but you could, because it's going to get propelled down to the stomach. And the muscle is what propels it to the stomach. And in order for muscle to contract, it has to be told to contract. So if there's a problem with the nerve, that demyelination, losing that myelin, then the signal is not going to make it down the nerve. So now it becomes a nerve problem. And then that is never going to make it all the way down to the muscle. So the muscle doesn't contract, which is why people say, well, it's a problem with muscles. Well, it's actually a problem with the nerve, specifically the demyelination of the nerve. So yes, if a person has a problem with their nerves sending signal to the muscle, well, that could include the muscle in their esophagus.
Don't they have another disease? It sounds like MS. I think it's called muscular dystrophy.
Muscular dystrophy, yes. Muscular dystrophy is the result of the body producing less dystrophin, which makes up part of the skeletal framework in a muscle. Yes, muscles have sort of a skeleton. So this protein helps to create this skeleton-like framework in muscle. So if the patient isn't making dystrophin or making less of it, then their muscles are going to be very weak. And they're not going to be very useful.
This is the one that I meant to bring up to you, not multiple sclerosis.
Multiple sclerosis is the MS. Muscular dystrophy is different, yes. But again, we're talking about muscle weakness. So if the nerves are sending a weak signal, there's going to be muscle weakness. If the muscles don't have the strength because they don't have that skeletal system, they're going to have muscle weakness. It's going to be in both of these. Okay. Don't remember where I was now. I think we're moving in, totally forgot. I think we're moving into the gastrointestinal system now, if I remember correctly. Yes, digestive system. Oops, that shouldn't be there yet. Nope, that's not what I wanted to do. That's what I meant to do. There we are. Okay. The anatomy of the gastrointestinal system is fairly simple. It's really simple. One big long tube. Some accessory organs to go along with it. Remember the pharynx, the throat, is a passageway that we share when we're using our respiratory system. But the food going down the esophagus has to go through the thoracic cavity into the abdominal cavity. So that's below the diaphragm. What that means is the esophagus going through the diaphragm, there must be an opening in the diaphragm, what we call hiatus. And there is. And you can see the stomach right here. So if I were to ask where the stomach is located, you could see that it's in the abdominal cavity in the upper left quadrant, mostly. This is important, and this is why words are really important when it comes to medicine. Because if a patient says they have a pain in their stomach, and then they point down here, well, that's not their stomach. That's their abdomen. If they say they have a pain in their stomach and they point over here, well, that's not where the stomach is located, not normally at least. So this is why we can't use that term stomach to describe this whole area. The stomach is one organ right here. It's not even the biggest organ in the abdominal pelvic cavity.
Dr. Sturgeon, how is it that they adapted to calling the whole abdominal area the stomach?
I don't know. But if I could go back in time and just, well, I don't want to do anything, and educate that person, that one person who started the whole thing, and say, look, man, that's not your stomach. This is your stomach. Pass it on. Yeah, I don't know. And it continues to perpetuate. I can't tell you how many times I've heard women say, when discussing pregnancy, talking about a baby in their stomach. No, hopefully there's not a baby in your stomach. That means you ate the baby. That's not good. It's in the uterus, in the abdomen, in the abdominal pelvic cavity. So I don't know who started that, but yeah, I wish we could have a talk, because I'm sure not one person started it, but you get the idea. But this is why it's important in medicine that we use the correct terminology. Because that's a different diagnosis. If they say they have pain right here, that's a completely different diagnosis. The stomach then connects to the first part of the small intestines, which happens right about here. Actually, right about there. So the first part of the, right about here is the end of the stomach and the first part of the small intestines. And then you could see here, there's a whole bunch of small intestines, about 20 feet right there. And then the large intestines, starting here, go up this way, then across, and then down to the rectum and the anus. So when you eat something and you chew it up and swallow it, the first part, the first third actually of your esophagus, the top third of your esophagus is under voluntary control. In other words, if you want to swallow something, you have to make that happen. But then once you get past that first third, then everything else is involuntary. The control, pushing the stuff through, is all involuntary, all the way down through until once again you get to the anus, where you have control, hopefully. Now, this is kind of important. I'm not going to go into the different layers of the gastrointestinal system, but I'm going to show you this picture. This is a typical part of the gastrointestinal system, like the small intestines, for instance. And you'll notice, here's the lumen. That's the area where the food stuff will be traveling through. And there's a bunch of different layers surrounding it, including these layers of muscle. Circular muscle, longitudinal muscle. So that inner layer of muscle is going around it like rings. The longitudinal is on top of it, where you can see the line sort of drawn in the same direction of the lumen. So why do we have muscle here? Well, we have muscle so that we can push things through. But why do we have muscle in two different orientations? In other words, why is one circular, one's longitudinal? Well, because we want to create a directional push. If all we had was muscle going around it, for instance, and that muscle contracted, it would push things in both directions. Kind of like if you got a tube of toothpaste and just put your hand right in the middle of it and squeezed. Some stuff's going to go to the end, some stuff's going to go to the opening, but it's going to get squeezed in opposite directions. So we want to use that circular muscle to squeeze, but then we want to use that longitudinal muscle to create the direction that we want it to continue. So everything that's flowing through here is flowing in one direction. Again, that is a wave-like motion we call peristalsis. We actually see the same thing in the blood vessels, in those arteries, helping to push that blood, creating that unidirectional flow. And you'll notice there's muscle, and if there's muscle, muscle has to be told to contract. So there must be nerves, and there are. So just a typical part of the small intestines in that case.
Dr. Surgeon.
Yes, yes, yes. Echo, yes.
So the nerves is what controls the muscle?
Nerve always controls muscle. Yeah, muscle contracts, that's its job. But in order for muscle to contract, it has to be told to contract. It doesn't know. So a signal has to travel down a nerve and tell it it's time for you to contract.
Okay.
This is just true with muscle. Now, heart muscle has a little bit of independence. It still gets that original signal from the sinoatrial node that sends out that electrical signal to contract. And then that signal can travel from cell to cell to cell. It's a little bit different. But I would hope so, because our heart is pretty important. It's a little bit different as well. We talked about the lips already, the cheeks, create boundaries. That's a good way of putting it. Hard palate is made up of bony parts, maxillae and palatine bones. Soft palate is really just soft tissue. So if we open up the mouth, looking in a mirror, stick out a tongue, say, what do we see? Well, we see the teeth, obviously. Those are good for chomping and chomping and chomping things. We see the tongue. The tongue is important for moving things around in the mouth and also moving it to the back, moving it to the pharynx, because we want to be able to swallow that stuff. So the tongue is going to play a big role in moving that stuff backwards so we can swallow it. Then there's a little punching bag hanging right down in the middle. That is the uvula. And the uvula is going to initiate the gag reflex. And there's lots of variation with the uvula that you'll see in patients. Looking back, you can see they've made them in yellow, so they're easy to spot. You can see the palatine tonsils. Remember I said those are the ones when people say they have to get their tonsils taken out. Those are the ones that would come out. The pharyngeal, the adenoids is the term that you usually hear. You can't see those in this image. They would be above and behind the palatine tonsils just a bit. And way back here, what they call the fauces is actually the oropharynx, the middle of the throat, way back there. Now, do we taste with our tongue? Of course not. We don't taste with our tongue. You know this. We taste with our brain. However, there are switches that get activated or not on the tongue. That's what people would call their taste buds. And those switches are going to send a signal to the brain where taste is interpreted. There is the lingula, which is that frenulum, that little lingual frenulum, excuse me, that little membrane of tissue underneath your tongue, right in the center, helps keep your tongue in place. This is why you're not going to swallow your tongue. First of all, you can't swallow your tongue. In order to swallow your tongue, you'd have to bite it up, chew it, and swallow it. When people say the person could swallow their tongue, what they mean is the tongue might block the patient's airway. But the reality is that's really unlikely. A time where the tongue could block the airway is if it's really, really swollen. And we could see that in a specific type of infection called Ludwig's angina, where there is a mixed aerobic and anaerobic infection, bacterial infection of the tongue. And that could cause it to swell up enough to where it blocks the airway. But trying to just get the tongue to move backwards like that doesn't really work out too well, because that little frenulum, that's okay.
How about if you have an allergic reaction? Could that happen?
Yes, but again, it would have to be a strong enough allergic reaction that would probably be causing other cells to swell up as well. That would be more life-threatening. But sure, it could happen.
How about during seizures?
Yes, a person will not swallow their tongue. Their tongue will not block their airway. Never ever put anything in someone's mouth who's having a seizure. They can bite their tongue, but that's not a big deal. I've only seen in my time working in medicine, I've only seen an emergency department 2 times where someone has bitten through their tongue. Both times they were children, and both times it wasn't during a seizure. It was because they were jumping from furniture to furniture. 2 separate children, 2 separate times, not in any way related, other than the fact that they both had bitten through their tongue, and they both were doing it from the same thing, from jumping from furniture to furniture, and they missed, and they came down on their chin with their tongue sort of between their teeth, bit clean through it. Not bit it off, just bit through it. So if you want to have a bad day, try suturing a child's tongue. Try putting sutures in that. They are not happy. It takes about 10 people to hold the kid down. Someone's got to hold their mouth open. Someone's got to have some gauze, grab a hold of their tongue and pull their tongue out of their mouth. And then somebody else is injecting lidocaine right into their tongue. It's a horrible, horrible thing. I feel terrible for those kids. But it's got to be done. And then you get to suture their tongue up. They are not happy with that. Someone's having a seizure, do not put anything in their mouth. Okay, I'm going to talk about the salivary glands here actually. We make saliva to help in moistening the food so that we can swallow it. Saliva also has some enzymes in it, well, specifically has amylase in it that helps to break down carbohydrates, although it doesn't get activated until it hits the stomach. So a lot of people will say that you start breaking down food in your mouth because saliva has an enzyme that breaks down carbohydrates. Well, it does, but it doesn't start working until everything gets down to the stomach. That's when that enzyme gets activated, and that's when it starts breaking down carbohydrates. What else does saliva have? Saliva has an antibacterial property to it as well. So if a person has chronic dry mouth, they're more likely to have more bacteria in their mouth. which means more dental caries. So these are the reasons why we have saliva. And the three glands are the parotid gland, the the submandibular gland, and the sublingual gland. The parotid one's sort of in the cheek, and the parotid duct, it shows it here being a little high. It's actually a little bit lower than that. You could actually pull your cheek to the side, and if you look on the inside of your cheek, you can kind of see the opening to the parotid duct. And although the parotid gland is kind of the biggest one of the three, the submandibular and the sublingual actually make the most saliva. That's all I'm going to talk about saliva. I'm also not going to talk a lot about teeth. Teeth are designed to cut, tear, and grind food up, but you know that. I'll show you the different parts in a minute. Baby teeth are known as deciduous teeth. You probably haven't heard that term because most people just call them baby teeth. And of course, permanent teeth are permanent. So the three main parts of the tooth, the crown, the neck, and the root. Looking at the inside, you'll notice that there is blood supply in that pulp. And then the dentin is the area around that pulp, which has the enamel on the outside. The enamel is the hardest substance in the body, but it has to be because it takes a lot of abuse as you're chewing and grinding stuff away. It has got to be pretty solid. And notice how that tooth goes all the way down into bone. So if that tooth is removed, there's going to be an area of empty space here that is going to fill up with bone. So if a person has many teeth removed, like if they're getting dentures, for instance, all that bony area is going to fill up, which actually is going to, the space that's right here is going to close up a bit. That means the shape of that bone is going to change a little bit. And if the shape of the bone changes, the shape of the face will change as well. But this is not a dental class, and I am not a dentist. So deciduous teeth, baby teeth, adult teeth. The really nice thing about this is it just puts them side by side, and you can see how many there are. Notice the third molar is called the third molar. Wisdom tooth is not technically a medical term, but that's how everyone knows them, the third molar, or the wisdom tooth. So it's actually the third molar. Oh, there was one other thing I wanted to mention back here. This is important. Mastication is the chewing. And then when you have to move that chewed up stuff back to your throat with the help of your tongue so you can swallow it, this is deglutition. So good terminology to know. Mastication is the chewing part. Deglutition is the movement so you can swallow it part. We talked about the pharynx. Again, the pharynx is the throat. The esophagus. The esophagus is a flattened muscular tube. They say collapsible, I say flattened. It is a flattened muscular tube that goes from the throat to the stomach. There are a couple of doorways called sphincters. We'll see the one I'm going to talk about the most is this one right here. the lower esophageal sphincter. That is a muscular doorway between the esophagus and the stomach. Notice the diaphragm, the stomach beneath it, the hiatus, the esophageal hiatus of the diaphragm, so the esophagus could go through it. I'm not going to worry too much about the upper esophageal sphincter because clinically, the lower esophageal sphincter is the one you're going to hear about the most. Gotta move on here a little bit. Let's look at the stomach then. The stomach is divided into these 4 areas. Sometimes they'll include a 5th area. The cardia is near, well, you can see where it is. It's kind of close to where the heart would be if you look above the diaphragm. The fundus is the round domed shaped part of the stomach. This is a good term to know. The fundus is the round dome-shaped part of the stomach. I say it's an important part to know because the urinary bladder also has a rounded dome-shaped part that can be called the fundus. The uterus also has a rounded dome-shaped part that is called the fundus. So the fundus is a good term to know when you're thinking of these rounded dome-shaped areas. The majority of the stomach is made up of the body, and then the end of the stomach, to where it connects to the first part of the small intestines, is called the pylorus. Now, the area right here leading up to the pylorus is referred to as the antrum. So some books will include that as a 5th part. Other books will include it as part of the pylorus. So let's look at a little more detailed drawing here of the stomach. Notice the esophagus coming into the stomach. That muscular doorway, that lower esophageal sphincter, sometimes called the cardiac sphincter, but most people call it the LES, lower esophageal sphincter. That is really important. It is really important because that helps to keep stuff from the stomach from going backwards up into the esophagus. And the stomach makes acid that is very, very strong. It makes acid that is so strong, it can actually damage itself. So the stomach also makes a mucosal lining so that it protects itself from the acid that it makes. The esophagus only has a thin lining of mucus. So if that stomach acid moves up into the esophagus past that lower esophageal sphincter, then the cells in the esophagus are going to get damaged. And that's going to tell the patient, we're getting damaged, which is going to be interpreted as pain, a burning sensation right in that area, which is why people call it heartburn, even though it's not the heart that is burning, it is the esophagus. So that lower esophageal sphincter is really important in helping to make sure that things do not go backwards up into the esophagus. And if that lower esophageal sphincter fails, then the person can have chronic acid moving up into their esophagus, which means chronic damage, which after a while is going to cause the cells to change. And you know, when cells change, we call that cancer. So yes, it can lead to a type of esophageal cancer called Barrett's esophagus. That's why doctors take that pretty seriously. Lesser curvature, greater curvature. And notice the stomach has linings of muscle. Longitudinal muscle, circular muscle, and even muscle at an angle. That is the oblique muscle. Why does the stomach have muscle in so many directions? Because we want the stuff that's in there to mix around, kind of like a washing machine. So we have muscle going in all these different directions so that it can help mix everything around mix it with the acid and the enzymes to help break stuff down, start that chemical digestion of food. And you can see in here, there are these ridges called rugae, which are going to allow for expansion of the stomach, kind of like an accordion, so it can hold more. Then you see here, there is another muscular doorway, the pyloric sphincter. So we have one at the open at the esophagus, and then we have another one at the end of the stomach. Because when that stuff moves into the stomach, we don't want it moving backwards in the esophagus, and we don't want it leaving too soon. We want to keep this closed so that the stuff stays in the stomach anywhere between 30 minutes and 2 hours as it gets mixed around. Then that muscular doorway relaxes and things move into the first part of the small intestines called the duodenum or duodenum. Either pronunciation is fine. I say duodenum. I think most people stick with duodenum, but that is the first part of the small intestines. And the duodenum is only about 10 inches long. It bends around a bit. Inside of the stomach, we have these areas that make enzymes. And probably one that you'll hear me talk about a couple of times are the parietal cells. And the parietal cells make something called intrinsic factor. This is very important when it comes to our bodies absorbing vitamin B12. Our bodies will not absorb vitamin B12 all by itself. So it has to hook up, it has to join up, it has to attach itself with intrinsic factor. And now intrinsic factor and vitamin B12 together, the body can absorb just fine. So why do I bring this up? Well, if someone has had gastric bypass surgery where part of their stomach was removed, or maybe they were shot and part of their stomach was removed, then they're going to have less parietal cells, which means less intrinsic factor, which means they're not going to absorb vitamin B12 very well, which means they're going to have to get a whole lot of extra vitamin B12 as a supplement. The stomach is where chemical digestion begins, breaking things into smaller parts. It's also where we kill a lot of things. That acid is great for killing stuff. So the small intestines begins with the duodenum or duodenum. Notice the diameter, about 1 inch. The first part, the duodenum, I thought there was a good picture of it, I'm sorry. The first part, the duodenum, oh, I know, there's a picture. It hooks around the pancreas. And this is where a lot of enzymes from the pancreas and then bile from the liver and gallbladder enter. So the duodenum is an important place for those things to enter, for those enzymes to come in so they can mix with this stuff that just came out of the stomach. We call that food stuff, as it leaves the stomach, we call it chyme, C-H-Y-M-E. And it's mostly liquid, and that moves into the duodenum, mixes with enzymes, gets broken down even more as it's moving through the next parts of the intestines. So not really anything gets absorbed in the stomach other than alcohol, like ethanol, like you drink, and aspirin, another good one. And then not much gets absorbed in the duodenum. Iron gets absorbed in the duodenum. but most absorption happens in the rest of the small intestines, the jejunum and the ileum. The jejunum is about 8 feet in length, and the ileum, spelled I-L-E-U-M, is about 12 feet in length. So all of the small intestines together is about 21 feet if you include the duodenum. Ileum, I-L-E-U-M. Remember, ileum, I-L-I-U-M is that flat bone of the pelvis. I-L-E-U-M is the longest part of the small intestines. So the absorption takes place in the jejunum and ileum mostly. Inside of this tube, there are these projections from the cells that kind of look like cilia. In fact, they look a lot like cilia. The difference is these do not move. The only reason they are there is to increase the surface area, to allow more things to be able to get absorbed into the cells and then into the blood and lymphatics, as shown here in green. So those food particles are then going to get absorbed into those villi, those projections and the microvilli, and move from there into the cells and into the blood. The large intestines is only about 6 feet in length. So the question I often get is, then why is it called the large intestines if it's shorter? Well, the reason for that is because the diameter is much, much bigger. And let me show you. Here is a good image of the large intestines. So as things move through the jejunum and the ileum, absorption is taking place. And remember, if things can't get broken down, if they can't get absorbed, they just keep going through. So here is the very end of the ileum. And what's left over is going to move into the first part here of the large intestines. And that first part is called the cecum. And you'll notice that off of the cecum, there is something called the vermiform appendix, although most people just call it the appendix. It's a couple inches in length. And actually, if you were to look down in there, you would see an opening kind of like this, except it would be going down into this dead end tube. And people think that the appendix doesn't have a purpose. That is not true. It is much like the tonsils, helps to get rid of, or helps with as a part of the immune system. However, just like the tonsils, it can become more of a problem than it's worth, especially if it gets infected. So that's why people would have that taken out if there's a problem with it. So the leftover stuff moved from the ileum into the cecum. Then that leftover stuff moves up. This is called the ascending colon. Then there's a bend. And a bend is called a flexure. And because this bend is over near the liver, we call it the hepatic flexure. So then that extra stuff, that leftover stuff, moves through the next part that goes across, and that is called the transverse colon, because it goes transversely, it goes across. Then there's another bend, this time over near the spleen, which is why it's got the name splenic flexure. Then the large intestines goes down, which is why it's called the descending colon. Then it moves into this S-shaped part. It's kind of hard to see it as an S-shaped part here in 2-dimension, but in 3-dimension, it becomes this S-shaped part called the sigmoid colon. Now, why the sigmoid colon? Because sigma is the Greek letter S. Then it moves into the rectum, which is the straight part, which finally goes to the anus, where you find there's actually 2 sphincters here. And that's it. Well, for the most part. So look at how easy they named this. The cecum is that little pouch at where the colon begins, the large intestines. Then it goes up, so they called that the ascending colon because it goes up. Then it goes across, so they called that the transverse colon because transverse means across. Then it goes down, so they called that the descending colon. Then it becomes S-shaped, so they literally called it the S-shaped part, the sigmoid colon. Then it becomes straight, so they literally called it the straight part, because remember, rectus means straight. Fairly easy to name this. You can see these puckered areas here called haustra. I just saw the name, there it is, haustra. And what that does, the haustra, these puckered areas, allow for expansion so that the body can hold more waste. You can see this yellow fan part in the back with all the blood supply going to it. That is called the mesentery, and that is continuous with a double layer membrane that we have in the abdominopelvic cavity, which kind of makes sense because we had a double layer membrane around the heart, we had a double layer membrane around the lungs. Now we have a double layer membrane for the abdominopelvic cavity called the peritoneum, which is continuous with the mesentery and the omentum. The omentum is a big, ugly, yellow, fatty pad that hangs down over top of everything else. Kind of helps protect it, keep things in place, hangs off of the stomach, the omentum. Now, I did tell you that most things get absorbed in the small intestines. And what's left over is just leftover, just waste. What are you going to do with it? Well, I'm going to move it out. However, we do still have the...
Sir?
Hold on one second. We do still have the ability to absorb some things in the large intestines. So we can absorb salts, we can absorb water. In fact, we have a lot of the ability to absorb water occurring in the large intestines. And we can absorb things like vitamin K, because there are bacteria that live here in our intestines, and they make vitamin K. And they don't want it, so we take it. So we can absorb some things in the large intestines. Yes, what is your question?
No, I was going to say, you said something about peritoneum, but I was thinking maybe I misspelled it as perineum.
Yes, you misspelled it. Perineum is different.
Okay.
Perineum is the area that we'd find between the scrotum or the vulva and the anus.
Okay.
Peritoneum.
Yeah. Okay, thanks, sir.
Yep. You see, peritoneum, there it is. Being demonstrated here in that blue. Notice that some things like the pancreas are in the retroperitoneal space, as is the kidneys. It's not showing the kidneys on here though. I wish it would have shown the kidneys, because the kidneys are also in the retroperitoneal space. Behind the peritoneum, in other words. Okay, I talked about the appendix. There it is. It's unfortunate they don't show a good picture of the omentum. I would strongly recommend at some point you take a moment, I don't know if they have it in the book, but you find a picture of what the omentum looks like. Don't worry about greater or lesser, just generally speaking, the omentum. Well, the greater ones obviously is going to be much bigger. You'd be surprised. It's a big, ugly, yellow, fatty pad. Okay, here is an organ that we consider an accessory organ of digestion. Oh, okay, don't want to do that just yet. Good. The liver is the largest solid organ in the body. Does over 500 different things, but as part of the digestive system, it makes bile. And bile is going to break down fats. Not going to worry about the different lobes right now, but you can see the general shape of the liver. You can see the location of the gallbladder. The gallbladder kind of looks like a deflated green, ugly pear that sits just underneath the liver. As we'll see, it is going to concentrate bile. So this is a pretty nice little diagram, because what it's showing is it's showing how that portal vein enters into the liver and then branches off. Remember I said the portal vein is not a true vein, because veins typically go and attach to bigger veins, and then bigger veins, and then bigger veins, and then the vena cava. These, however, this one, the portal vein, branches off into smaller veins again as it enters into the liver. And the reason for this is because the portal vein is, and the blood coming into the portal vein, has just absorbed nutrients from the intestines and the stomach. So those things have to get sorted out, and that's what the liver is going to be doing here. It's going to decide what to do with these nutrients that just came into the body. Do we store them? Do we keep them in the blood? What should happen? And then you can see they come back together as a hepatic vein, which eventually is going to attach to the inferior vena cava and bring that blood back to the heart. Here's the picture I was looking for before. So notice the pancreas. Now the pancreas, you recall, is located posterior to the stomach. This lumpy yellowish gray colored, kind of triangular shaped gland, I think, that has the body that is tucked inside the duodenum. I'm sorry, the head of the pancreas tucked inside the duodenum. And then the body, the long part, and then the tail that points over to the spleen. But this is a nice image because it's showing how the stomach would end. This would be the end of the stomach where the pyloric sphincter would be. And this would be the start of the duodenum, the first part of the small intestines, and how it wraps around that pancreas. And you can see the ducts from the pancreas that are going to empty lots of enzymes into this area. And you can see how the ducts coming from the liver and the gallbladder connect into a common duct, the common bile duct, and that is going to release bile. And bile breaks down fats. Bile's that yellow, bitter tasting stuff that you throw up after you've thrown up everything else. So the liver makes the bile, and the gallbladder can store the bile and concentrate the bile and then squeeze it out when it's told to. When a hormone called cholecystokinin says, squeeze out the bile now, that's what will happen. The liver does a lot of things. What else does it do here? It doesn't say it, does it? Produces important plasma proteins. Okay, it also produces the vitamin K dependent clotting factors as well. That should be in there. That's a pretty important one. Oops, shoot. Main components of bile are bile salts, bile pigments, and cholesterol. That would be like bilirubin, for instance. The gallbladder stores the bile, concentrates it, and squeezes it out. In some cases, it can precipitate. The bile can precipitate inside of the gallbladder and form stones. Those are gallstones. They're also known as cholelithiasis. And that can cause pain when the gallbladder squeezes, try to get this stuff to come out. We've talked about the pancreas, where it's located and what it's going to be releasing. We know the importance of the beta cells secreting insulin and the alpha cells secreting glucagon. Ingestion, food taken in. Digestion, broken down into smaller nutrients, smaller particles. Secretion of enzymes help to break those things down. Absorption is when it's actually moving those things into cell and then into blood. Elimination, getting rid of what it cannot break down, cannot absorb. Of course, there's going to be a regulation to it. Okay, getting close. I talked about mastication, the chewing part. I talked about deglutition. That's the part where you move it to the esophagus so where you can start to swallow it, and then you swallow it. And that is shown in this diagram here. Here's a term you've heard me say a lot now, peristalsis. This is the same action that pushes blood through arteries. That muscle, the layers of muscle that contract, create this wave-like motion, pushes food through everything. And this, another term you've heard me say, chyme, C-H-Y-M-E. Emptying, it says here, emptying the stomach takes about 2 to 6 hours. That's kind of on the long side. It's usually closer to like 2 hours. That's why I said on the short side, 30 minutes to 2 hours. 2 hours, 6 hours, a long time. So a better average would be like 2 hours, just split the difference. So that food stuff that you ate, you chewed it up, so it mixed with saliva that's in your mouth. It also mixed with mucus that is in your mouth, as well as in the esophagus. It moves into the stomach where there's more mucus, but there's also acid. There's also enzymes that are going to really break this stuff down. Chyme is mostly liquid. It's a thick liquid, but it's mostly a liquid by this point. Chyme. And this is showing that peristaltic action to move things in one direction and breaking things down. This is nice. It's showing the machine, the washing machine-like motion of the stomach. Things getting swished around. Chemical digestion, hydrolysis. Lysis means to break apart. Hydro means water. Breaking things apart using water, hydrolysis. Chemical digestion, we're out of time. Enzymes. Remember, we make two things more than anything else. We make energy and we make proteins. Some of those proteins are going to be structural proteins, for instance, building things up, making things. Some of those proteins are going to be enzymes that catalyze reactions. But remember that enzymes I don't know why they say organic compounds. That's not a really good term. Enzymes are proteins. Don't call them organic compounds. Enzymes are proteins that catalyze reactions. They make things happen. There's a lot that our body needs. Carbohydrates are broken down by amylase. And you can see in the bottom here, enzymes, catalyze stages, sucrase, lactase, maltase, amylase. They all have something in common. ACE, protease, peptidase, RNase, DNase, lipase. As we'll see coming up. If it ends in an ASE, it is an enzyme. If it ends in an OSE,
Sugar.
It's a sugar. Very good. Here is a carbohydrate, long chain branch sugar. Coming in, we're going to break it down into smaller parts, disaccharides in this case. Then we're going to break it down into individual monosaccharides, individual sugars. Now we can actually absorb those things. Proteins are going to come in. We're going to break them down using enzymes as well. Where's the image here? So we have proteins that come in. They're going to get broken down into eventually amino acids. Amino acids, you'll recall, are like Lego blocks. The building blocks of proteins. Remember I said, just like Legos, you can take them apart and snap them back together, and take them apart and snap them back together, build up different types of proteins. As was pointed out earlier, one of the reasons we eat is to get proteins so that we can break them down into their individual amino acids, their building blocks, and then build them back up again, snap them together. Now, would you be at all surprised to find out that this enzyme right here breaks down fats? You shouldn't be, because it ends in A's, so you know it's an enzyme. And lipo means fat. So here's an enzyme that breaks down fats, lipase. Emulsification, the process of breaking down fats using bile. Emulsification. Oh, there was an enzyme I passed up back here, sorry. Lactase. Lactase breaks down what sugar molecule?
Lactose.
There you go, lactose. Lactose is the sugar molecule found in dairy products, right? So it is glucose and galactose together. That's too big for us to absorb. But if we could break it down into individual parts, glucose and galactose individually, well, that will be just fine. So as long as we have that enzyme, lactase, then we'll be able to break those down into their individual parts. I talked about saliva already. I talked about the parietal cells, the intrinsic factor. Remember, that's important for vitamin B12. Pancreatic enzymes. Now, trypsin is an enzyme, but it doesn't have that A's on it. Amylase, that's the same amylase that is in your saliva, breaking down carbohydrates, lipase. RNase, DNase, or different nucleases. Talked about that. Goblet cells, I mentioned those already. Goblet cells make mucus. Remember, MUCUS. Mucus, MUCUS is the sticky stuff. MUCOUS is the type of cells in the lining that make the mucus. Should include that. That's something that I want people to remember. MUCOUS. Mucus is the tissue / cells that make mucus, MUCUS. The sticky stuff. So when you see two spellings for the word mucus, this is why. MUCUS is the actual liquidy sticky stuff. MUCOUS is the type of cell or the type of tissue that makes the liquidy sticky stuff. And I see that we are almost out of time, but we are really close to being to the end. Okay. Olfactory visual stimulation can cause saliva to start being released. So when you're standing in line, waiting to order food at your favorite restaurant, I don't want to mention what name of that restaurant, but you know, you're loving it. As you're standing there, you're smelling the food, you're thinking about what you're going to order. Your brain already says, all right, we're getting ready to eat. Let's make some saliva. So it'll make it easier. And once you start chewing, even your body, your stomach will actually start making acid, getting ready. CCK is cholecystokinin. That's the thing that's going to cause the gallbladder to contract and release bile. We talked about absorption. Absorption of water is simple and straightforward. Osmosis, you remember that? Water is going to move across a selectively permeable membrane from an area of low solid concentration to an area of high solid concentration. Defecation is the release, getting rid of the leftover stuff. Constipation is when things are moving too slowly. If you look at every over-the-counter cure for constipation, they all have the same ingredient, fiber. That's all it is. You increase fiber in your diet, that'll draw more water into the lumen of the large intestines. That'll soften everything up, move it through quicker. Diarrhea, RRHEA, means excessive flow. Dia means complete. Diarrhea, things are moving so fast, it cannot absorb that extra water, and everything comes out, well, liquidy. That's one of the main reasons. That's why if a person takes Imodium, that is over the counter, that'll actually slow the process of this movement through the small intestines, allow more water to be absorbed, stop the diarrhea. Okay, so with that being said, you now have a quiz that starts right now. You should have access to it. Let me check real fast. And I will say that ends the lecture on digestive system and the respiratory system. So make sure you watch this video again. Remember to like and subscribe, leave a comment below, and check out the merch store. All right. Have a good rest of your day. Goodbye.